Good morning, everyone. My name is Alan Rothman from University of Rhode Island. Thanks for coming back for the session number 2, Can We Talk? Immunologic Crosstalk Between Flaviviruses. So we have a great group of speakers for this morning, and our first speaker is Dr. Kathryn Anderson. Dr. Anderson is Associate Professor here at SUNY Upstate Medical University, and her topic is Beyond the Serotypes, Clinical and Immunologic Impacts of Heterologous Flavivirus Exposures on Subsequent Dengue.
Thank you, Alan. Morning, everybody, and thanks for the opportunity to present today. I want to say just out of the gate that putting this together was somewhat of an awkward experience for me in recognizing that it's complicated enough with 4 serotypes, and do we really want to be thinking about, do we need to be considering other flaviviruses? But my goal in this talk is to go through what we have observed and what we know about how non-dengue flaviviruses might impact dengue, to use various examples over time about the clinical, immunological, epidemiological interactions between different flaviviruses, and then hopefully hone in on some clear priority questions, given that there may be near infinite possibilities in terms of all the different flaviviruses, the sequence of infection, all the different factors to consider. What do we really need to know with dengue in mind? Let's see. How do I advance, Alan? Sorry. Oh, got it. Thank you. Excuse me. So this is a schematic of the phylogeny of the flaviviruses. Here we can see the grouping of the dengue serotypes in green to the side. Zika would be in there as well, also closely related to West Nile JE. A little bit more distantly related is yellow fever, and then we can see a distinct grouping of tick-borne flaviviruses there in red, and then more distantly related is Hep C. So this is a pretty heterogeneous group of flaviviruses in terms of their modes of transmission, in terms of their ecology, and interestingly, you can see groupings as well in terms of how the viruses are spread. So distinct groupings of the Aedes transmitted flaviviruses as well as the Culex transmitted flaviviruses. Despite all of their differences, there is somewhat significant overlap with about 40% amino acid homology in the envelope protein between these viruses, and of course more homology still between the different dengue serotypes. So why are we talking about this? So beyond the fact that they share some sequence homology, these flaviviruses also overlap significantly in terms of geographic range. So of course this is the distribution of dengue, as we all know, widely spread throughout the globe in terms of tropical and subtropical regions of the world. But there's also significant overlap with the distribution of yellow fever, shown here, predominantly transmitted in South America and sub-Saharan Africa. This is the distribution of Zika. As we all know, in 2015, the global spread in the pandemic of Zika, where it was spread really in a distribution that overlaps dengue and then some. And we know that Zika continues to circulate at lower levels and with a lot of uncertainty currently, but in a range that certainly overlaps with dengue in many places. And then finally, Japanese encephalitis, primarily being transmitted in Asia and Australia. And I think to hone in on these 3 flaviviruses in particular as priority areas of interest in terms of how they interact with dengue. It's also important to say that while JE infection in humans may be somewhat rare, certainly understudied, the same with yellow fever, vaccination is somewhat widespread in many parts of the world. So for example, here we're looking at the proportion of individuals in areas where yellow fever is transmitted who have been vaccinated, and in some areas it's upwards of 60 or 70% of the population or even higher. This is data from our family cohort study showing by age the proportion of individuals who reported that they'd been vaccinated against Japanese encephalitis virus. So in Thailand, where we work, Japanese encephalitis virus became part of the EPI, or the expanded program on immunization, in the late 1990s or so. It began to be introduced. And so in our cohort, we can see that starting at about the age of 40, there's this steady increase in vaccination to the point where now children who are in our cohort study are about 95%, 100% vaccinated against JE by the time they're 1 year old. So often, even before they're exposed to dengue for the first time, they've acquired a flavivirus exposure in the form of JE vaccine. It's also important because this might also influence the interactions between JE immunity and dengue. The type of vaccine has varied over time, with inactivated vaccines being more prominent in the early years of the JE vaccine campaigns, which might generate a certain type of immunity, and now it's live attenuated vaccines and chimeric vaccines that are in broader use, which might generate a different immune phenotype still. So what do we know about how flaviviruses may interact? And while the goal of my presentation is to focus on the impacts for dengue, I'm going to go through a couple different examples of different types of flavivirus interactions, just to highlight what we may expect. And I initially had been saying, what do we know about how they interact? And I think going through all of this literature review and putting this talk together, we have a lot we don't know. So I'm just going to frame it as, what have we observed? So first, if we look at immunological interactions, it's clear that original antigenic sin can occur. So here we're looking at data from the epidemic of Zika in Yap, and looking at individuals who had had a confirmed Zika infection, and as a primary flavivirus exposure, we can see a very clear specific response by PRNT between the acute and convalescent specimen, which is nice. That's very clearly Zika. But if we look at a secondary type response amongst individuals who had Zika on Yap, we can see, as we would all expect, that it becomes muddy pretty quickly. We can see that amongst people who had Zika, for example, they may have had a more dominant response to dengue 2 or to dengue 1, but at times they might have had the strongest response to Zika. So it's far from predictable, and it is pretty unclear. This does suggest that there are some shared immunologic or antigenic epitopes that might drive some of this cross-reactivity. This is one example of several, and it's a kind of busy slide, but it's one more example of how pre-vaccination flavivirus immunity may impact the immune response to dengue vaccination. And there have been multiple studies showing that if you have some type of flavivirus immunity and you get the dengue vaccine or a dengue vaccine, in this case it's TV003, you may have a good type of ADE, resulting in a more pronounced response, maybe a broader response. So here we're looking at comparing individuals who were flavivirus experienced or flavivirus immune versus those who were naive, and their immune response to the 4 serotypes after their first dose, their second dose, and then out to 6 months or a year after their vaccination. And we can see, again, a higher titer response across all 4 serotypes, significant for some that persisted out to a year. This has been shown for multiple live dengue vaccines, but it's also important to point out with other types of vaccines as an analogy that we could expect that beyond this type of good enhancement where it gives a boosting response, there may be times where pre-existing flavivirus immunity could blunt the response to vaccination by neutralizing some of the live virus and preventing replication, or could skew the response by having original antigenic sin and a response that's directed towards the prior flavivirus. This paper was a delight to read. I recommend people look at it. This is looking specifically at how dengue might impact yellow fever disease. But this is looking at a cohort of people who were part of a naval unit in South America who experienced a yellow fever outbreak. And they looked at the individuals who became infected with yellow fever virus and characterized their immune patterns and tried to decipher if they had had prior dengue exposure or not. And what they found was, if we look at individuals who'd seemed to have been pre-exposed to dengue, they were no more or less likely to be infected. That rate was the same. But if they looked at the incidence of severe disease, those who had apparent dengue immunity were much less likely to have severe yellow fever. 10% of them developed yellow fever compared to 43%. And in this paper, they point back to even earlier evidence going back to the 1800s, where Napoleonic forces who were in Gibraltar, it was observed that individuals, troops who had passed through India before arriving in Gibraltar had a much lower case fatality rate from yellow fever, and led to this recommendation that troops, before they would arrive in Gibraltar, should be pre-seasoned, apparently with exposure to dengue in India before they would go on to fight. So there's clearly clinical implications of some of these interactions as well. And again, I recommend reading this paper. It's a delight to read. This was a manuscript looking at, within a longitudinal cohort of individuals being followed in Brazil, the impact of their dengue immunity prior to exposure to Zika on their risk of infection and their risk of illness given Zika infection. So again, this is looking at clinical outcomes as well as risk of infection. And I'll focus your attention on the blue lines in the middle, which are looking at the degree of pre-infection immunity to dengue, and we can see that it was associated with a decreased risk of Zika. Interestingly, in this study, they found an inverse association, well, they found a direct correlation between the presence of dengue IgG3 and the risk of Zika infection, which is interesting. So counter between total binding and IgG3, but overall, binding levels, higher levels of binding antibodies to IgG were associated with decreased risk of Zika, and interestingly, pre-existing immunity to dengue was associated with decreased risk of symptoms. So it appeared as though dengue was protective against Zika. This is a manuscript that came out of our collaborations in Thailand, looking back at a cohort study of school children back from 1998 and following them forward over time. So in this study, we're looking at the clinical impacts of Japanese encephalitis immunity on subsequent dengue. And individuals were characterized by PRNT as to whether or not they had dengue immunity on entry into the study. If they did not have detectable antibodies to dengue, they were characterized as dengue naive. And then we further classified them by looking at if they had JE neutralizing antibodies or not. And what we observed is that if you were dengue naive but had JE immunity, you were about 3 times more likely to be symptomatic given infection. And you had an elevated risk as well, depending on whether or not you had dengue multitypic immunity and JE or not. So interestingly in this study, the risk of infection was lower if you had JE immunity, but the risk of illness given infection was higher. In this study as well, among individuals who were dengue naive but had JE immunity, their duration of illness with dengue infection was about twice as long. And then finally, looking at epidemiological interactions, or kind of larger population scale interactions. This is just one of many studies that looked at the incidence of dengue following the Zika epidemic in South America in particular. And this study is highlighting that in contrast to prior years where dengue was somewhat predictably present, an epidemic every year, following the Zika epidemic shown here in pink, dengue was largely absent for several years. And in this study, they model and demonstrate that possibly it was enhancement driven by Zika that caused the large dengue spike in 2019, but that was based on modeling. In Thailand, the situation is a little bit less clear when we look at the interplay between dengue and Zika on the population level. So we know, looking at sequences from Thailand for Zika, that Zika has likely been present in Thailand for decades and decades and likely circulating at a lower level. And there was an epidemic of Zika in Thailand during 2015 and 2016. But if we look at the impact in terms of dengue cases that we observed in Kamphaeng Phet, it was marginal. Here we're looking at, in the figure, dengue cases at the Kamphaeng Phet Provincial Hospital that were confirmed by PCR. We can see epidemics every year of varying degrees. And if we look at 2016, we can see a pretty significantly decreased incidence of dengue, but just for that 1 year, and then it was pretty back to normal. And the Zika epidemic in that area was not as pronounced as in Brazil. So that raises lots of interesting questions about what's different about the epidemiology and the interplay of these two viruses in two different regions. So in thinking about how to frame this talk, and with dengue in mind, it seems as though what we really need to know is prior immunity to non-dengue flaviviruses, is it detrimental? Is it enhancing? Or is it an opportunity, and is it protective? Or is it both of those things at different times? And we need to understand the context, particularly with dengue vaccines in mind as well. So what do we know from dengue, and can this be informative in terms of trying to interpret the immunological and clinical consequences of non-dengue flavivirus exposures? So we're learning a lot over the last several years. We're starting to understand how specific immune phenotypes could drive enhancement or protection. So for example, we're learning a lot about how the primary antibody response to dengue following a first infection is directed towards fusion loop envelope. It's directed towards the fusion loop envelope proteins. These are cross-reactive. They are not very neutralizing, and this is driven by the variable availability of the epitopes between mature and immature virions. Looking at how this may play out with non-dengue flaviviruses, is it a similar thing where fusion loop envelope may be cross-reactive in driving enhancement? Here we're looking at sequential exposure to individuals who were exposed to tick-borne encephalitis vaccine and were subsequently vaccinated with the yellow fever 17D vaccine. So slightly different model, but what does this mean for dengue potentially? Here what I'm going to show you is before vaccination with yellow fever, we can see that individuals who'd gotten the TBE vaccine had broadly cross-reactive IgG antibodies, that's shown in the top left, whereas individuals who were not vaccinated with the TBE vaccine had absent cross-reactivity, which we would expect. Following yellow fever vaccine, we can see a boosted response across all flaviviruses in individuals who were primed with the TBE vaccine on the right, versus, interestingly, individuals who just received the yellow fever vaccine had a very specific response to yellow fever. So that's interesting in framing that the cross-reactive response, which we would expect, but it's a nice illustration, varies by which flavivirus you're talking about. Yellow fever is much more specific in this context. TBE was much broader. They then looked at what the implications were for enhancement. And in the lower left, we see that individuals who've been primed with the TBE vaccine were capable of enhancing dengue on the left, even before they got the yellow fever vaccine, but that following receipt of the yellow fever vaccine, their potential to enhance went up further. And the same is true for Zika, as is shown below. Finally, they went on to do depletion studies and demonstrated that amongst those individuals who'd been TBE vaccinated, that this enhancement was driven by antibodies against the fusion loop. So this does suggest, again, a potential for enhancement for dengue with prior exposures to flaviviruses, largely driven by these fusion loop antibodies. In contrast, there's growing evidence that these antibodies against quaternary epitopes, for example, the envelope dimer epitope, could be broadly neutralizing and could drive some of what we're seeing in dengue, where by the time you arrive at your third dengue infection, you're likely to be protected, even if it's a serotype you've never seen before. And this study, which has not yet been peer-reviewed, but just came up on medRxiv, potentially demonstrates this accumulation of antibodies against quaternary epitopes with sequential dengue exposures. So this is looking at individuals who were in the Philippines, some of whom received the Dengue vaccine, some of whom did not, and they followed them over time. In the interim, there was a large dengue outbreak, and many of them became infected. So what we're seeing here is looking specifically at antibodies against the envelope dimer epitope. We're comparing those who were unvaccinated in the orange, those who were vaccinated in the purple at baseline, and then after follow-up, again with the dengue epidemic coming in the middle. And what we see is an increase in EDE antibodies between those who were vaccinated and unvaccinated, and then it's boosted further in each of those groups in follow-up, where presumably many of them would have been infected with dengue, suggesting that you may see this increase in antibodies against quaternary epitopes with sequential exposures. This was a really nice study, I thought, based on a cohort in Taiwan where Zika did not circulate to a large degree. They had sporadic cases in travelers. And looking at the potential to neutralize Zika in individuals who had had various types of other flavivirus exposures. And so they're presuming that the vast majority of this cohort was not Zika exposed. But some of them had been exposed to dengue, some of them had been exposed to JE, and if they look at their potential to then cross-neutralize Zika, they see that if you'd been prior exposed to JE, they're presuming based upon the antibody profiles, and you have high levels of immunity to dengue, you can cross-neutralize Zika, suggesting that potentially with sequential exposures, you may be able to develop a broadly cross-neutralizing response. And in thinking about these interactions, in my mind, it would all fit very nicely if we could hypothesize that maybe these exposures just count as a dengue exposure. So in Thailand, within our cohort, if you get the JE vaccine, does that just count as one of your dengue exposures in terms of you get the JE vaccine, your primary dengue infection is maybe more like a secondary dengue infection because of your vaccination? And maybe in some settings, but it does not seem to be that clear. Because if we look at how this all comes together in the field, this was a nice study that we're all familiar with coming out of Nicaragua. I'll kind of orient you to this figure. So this is a cohort that's been followed longitudinally. There were various serotypes in circulation, and then a large Zika epidemic in Nicaragua is illustrated in the blue. Some period of time passed, and then there was a large dengue 2 outbreak. And as they looked at how do the pre-immune and prior exposures to dengue, how do they influence your response to dengue plus minus Zika? And what we see here is that, I'll have you focus in on maybe panel B, that some of these play out the way that we would expect. If you had had one dengue exposure before, you have the highest risk of dengue with warning signs with a subsequent dengue infection. That fits with all we would expect. We see that if you've had just Zika before, you have an increased risk of dengue with warning signs, which may support, okay, maybe that counts as a dengue infection in terms of priming you for severe disease. But interestingly in this study, if we look at individuals who had dengue and then Zika and then dengue again, they were at similarly high risk, as shown there in the blue. So this suggests that this is more complex, fortunately, unfortunately, and that this may vary, these interactions may vary depending on if your first infection was Zika or if it was dengue and where these things fall in the timing and the sequence. So unfortunately, what this means for us is that a complicated picture has become more complicated still, because I think the 4 dengue serotypes is complicated enough, but we have multiple instances where it's pretty clear that these do interact, and they likely interact significantly, particularly when we're talking about Zika and JE and potentially yellow fever. So not only do we need to think about what's the impact of prior dengue exposures, we need to think about what non-dengue flavivirus exposures have you have, when, what were they? Was it inactivated or a live JE vaccine, for example? How long has it been? And then the specific immune phenotypes. So it plays in further to this big, complicated ball of yarn that we need to untangle when we're trying to get at protective or pathogenic immune phenotypes for dengue. So where do we go forward with this? Why do we still have these significant gaps in understanding the impact of non-dengue flaviviruses on subsequent dengue infection? The problem is, just like it is for dengue, that most of the time we are not able to confirm or observe what someone's been exposed to in the past. That's why a lot of these examples are driven by vaccines and following people where we know they had a vaccine at this time and they subsequently got dengue. We don't know, for example, what the true incidence is of JE in a lot of the world. We don't know what the true incidence of Zika is in a lot of the world right now. So a lot of this is unobserved and not able to be inferred based upon a single serology sample. A challenge as well is that these relationships may be asymmetrical. So the interplay of, for example, tick-borne encephalitis and yellow fever may depend on which exposure you get first. And some of this makes sense in terms of the structure of the virions and what the antibody specificity is of your first exposure versus your second. So this is likely going to be quite complex. And the other thing I'd like to highlight is, with the Nicaragua study in mind, which was a great study and raises a lot of interesting questions, we have cohort effects in a lot of these. So for example, in that study, they found a significant relationship between Zika and risk of severe dengue with dengue 2, but that's what they had available to study with that amount of time between the exposures and in a cohort that had had shared exposures before that. So for a lot of this, we need to keep in mind the cohort effects in terms of when and what people are being exposed to. So with all of this in mind and the complexity of all of this, what should we focus in on? Because it is an insane amount of complexity. With dengue in mind, there's a few things that I think are somewhat low-hanging fruit and important. So the first is, what are the clinical outcomes of individuals who receive yellow fever vaccine, JE vaccine, and Zika infection on your primary and secondary dengue infections? The next is understanding how do these primary flavivirus exposures shape your immune response, and how does that change your immune phenotype before you get exposed to dengue as well as after? And this really gets down to one of our primary goals in dengue right now, or at least our group's primary goal, which is understanding what are correlates of protection for dengue. So what is a protective immune profile? How do we identify them? How do we get there? And are there common pathways that could be exploited? And then how can we generate them through vaccination? So ultimately, and possibly unfortunately, this involves long-term cohort studies, in my mind. That's what we do, so I have a bit of a biased lens, but we really need to be able to capture these sequential exposures, characterize when they happened, what's the resultant immunity, what is the immunity before someone gets infected with dengue, what's their clinical outcome, to really tie these together, because trying to piece things together and infer historical exposures is not going to get there. So this is my last slide, and this is precisely why we are engaged in collaboration with the Army and other academic partners in a long-term cohort study based in Thailand. I'll briefly comment on this. It was established in 2015 and involves about 3,000 individuals in multi-generational households. And the goal of this study is to enroll everyone from infants, you can see the top right figure, all the way out to individuals who are 90 plus in the households, and follow them over time with age through sequential exposures. And in particular, we think that this newborn cohort will be really valuable in terms of following hundreds of children as they are born, accumulate JE vaccine, dengue vaccine, Zika exposures, and try to start to tease this apart and relate it to immune phenotypes. Thank you.